To our webinar. We will be recording. The title of our webinar is Insights into Xylazine and Other Emerging Drug Supply Issues or Topics. And we have a wonderful group of presenters today. I'll have them each introduce themselves when they begin. We are using Zoom webinar, so only panelists and hosts can share video and audio. So please enter your questions and comments in the chat and the Q&A. And substance use and people who use substances are often very stigmatized topics, and so I encourage people to be really respectful and curious in any sort of questions and dialogue that we have. So before I get into the outline, I mentioned my name is Banta-Green. I'm a research professor at the University of Washington in the Department of Psychiatry and Behavioral Sciences. And we're going to be talking, as I said, through one of our projects here at the Center for Community Engaged Drug Education, Epidemiology, and Research. And the outline here is we're going to start off talking about, I'll start off talking about sort of the new messy drug supply. What are these substances and why are they in the drug supply? How often are we seeing these newer substances in the drug supply based on our community drug checking network, which I'll share about with you, as will Ben Biamont. So we're going to talk about what is that network and what are the data we're seeing sort of overall, and then also for xylazine and this newer substance, BTMPS. We're joined by Lex, who will share sort of their experience as a community drug checking network site, talking with folks about xylazine testing and what their conversations are like. And we're really fortunate to be joined by Carrie and Molly from Public Health Seattle King County, talking about drug-related wounds. What are they? Why do they happen? Why are they serious? And in particular, sort of xylazine wounds, what they look like and how they're treated. We'll have plenty of time for Q&A, and then we'll have some resources available for folks at the end. We will take questions at the end. If you have any immediately clarifying questions, if I lapse into using jargon or acronyms, I hope I don't, throw those in a chat, and Ali will step in and make sure that I correct those and clarify those. So, this new messy drug supply, just to share with folks, I've worked with folks who use drugs since 95, and I worked as a drug epidemiologist since 2001. And when I really started back in 2001, it was actually at the emergence of this new substance called methamphetamine, which is a synthetic drug, but it was really new in sort of its potency, its local production, its incredible in how inexpensive it was. And it was coming into a drug market that was predominantly plant-based drugs, cannabis products, heroin, cocaine, and everything about everything is sped up. Everything is moving, just literally exponentially faster in terms of what are the new drugs, what are the new drug patterns, what are the new drug contaminants. Everything is much, much faster. The trends are much faster. I used to map trends over the basis of years, and as you'll see today, some of the trends we're now mapping on the basis of weeks or months. Things are happening much more rapidly. So there's this rapid acceleration in these new drugs and these adulterants entering the market. And these adulterants, this term, I'm using it very loosely, but it generally can be things like a bulking agent or a cut, sugars and mannitol, just things that just cut or step down a drug to sort of decrease the potency and extend the amount that can be sold, essentially, as people may be familiar with. There may be other related drugs to sort of mimic the effect. Maybe they're easy to get or cheaper. There's usually a profit motive or when it comes down to why in the drug market, in my experience. The adulterant or the unexpected or unanticipated substance might be another drug that might extend or balance out or counteract the effect of the main drug. And in an instance with BTMPS, as we'll talk about, we really don't know why it's there. There's a lot of speculation. We may know in a month or a year, but it's really not clear at this point. And these adulterants may be pretty biologically neutral. They could be irritants or they could be incredibly dangerous. We just don't know out of the gate. So I'm going to hand it over to Ben, who I hope will introduce himself and talk a bit about our community drug checking network, and then I'll come back and talk a bit about some recent data.
Yeah, thank you, Caleb. So hi, everybody. My name is Ben Biamont. I use he, him pronouns. I am the day-to-day programs manager for the community drug checking program. So the community drug checking network, I'll just go ahead and read this real quick, is an approach to providing better informed, coordinated, and compassionate wraparound care for people who use drugs through a network of dedicated experts utilizing multiple chemical analysis tools and resources to provide people who use drugs and community stakeholders with often vital and novel information on the drug supply. So that is a very wordy summary for an awesome group of people who really care about people who use drugs and are doing all they can to collaborate and work together to sort of fill in information voids so they can help support the people who use drugs in making better informed decisions with the knowledge that drug checking can bring them. So I think on the next slide, yeah, so a little bit about the Washington Community Drug Checking Network. This can be very broad and very quick. So there's 7 full sites. Full sites use both immunoassay test strips, fentanyl, xylazine, benzodiazepine, methamphetamine test strips. And they also use and or will use an FTIR machine, which is a Fourier transfer infrared spectroscopy machine. And then the secondary samples are sent out to an outside lab to do a deeper and different sort of analysis on the sample. There's 2 light sites that are operating so far, and those sites are only offering immunoassay test strips, so those same test strips. And then samples are then sent out to the secondary lab, similarly to the full sites. This is a chaotic brain map of the community drug checking network. The biggest takeaway I would say is center and foremost, as it should be, is participants utilizing drug checking services and people who use drugs, whether they're accessing the service themselves or they have somebody who they have relationships with who is accessing services. And then it's these outlying sort of groups of individuals and people who are collaborating and communicating and sharing their expertise and knowledge through different means and outlets to then come together and have that better, more informed wraparound care for folks who are using drugs. So you can see we have the trained technicians on the outside, Lex being one of them, all super lovely, rad individuals. And they're doing the preliminary or the initial testing, like I had spoken about with the FTIR machine and the test strips. They communicate within their own organizations and folks accessing space within that organization. They're also communicating directly with the secondary lab, who is running the analysis on the samples that they did the preliminary on. And all of them sort of work together to get that information back to the participants and the folks accessing the space. And then sort of the ADAI University role is to help support more broad sort of community engagement stakeholders. So whether that's like EMS, hospitals, and then help bring the network together as all the technicians and the organizations themselves. So that is the very chaotic brain map of the Community Drug Checking Network in Washington. Just really quick before we dive back into the sort of data and what's sort of going on in the drug supply, I wanted to take a second and show this sort of interactive flyer. This is a replica, but it was originally conceptualized and created by a technician. Georgia, a lovely individual. They've done a few webinars with us. And this is sort of a creative approach as a way to increase interest and engagement with drug checking services at sites. And it's an interactive moment that can really foster in-depth conversations around health, harm reduction, and drug checking topics in general. So the concept here is looking at these samples, could someone figure out the sort of chemical makeup or the components of a given drug sample? The answer is usually not. Um, and it's kind of getting at, you can't always assume or guess the composition of samples through just using your senses, smell, touch, look, especially taste. So yeah, drug checking is awesome. The people who offer it are awesome, and the people who access the services are awesome. And this is a fun way to sort of tie them all together. Pass it back to Caleb. Caleb, you're muted.
Better safe than sorry. So that's my motto. So I want to share with you a bit of drug checking data, really because it's one of the primary sources we have on these new substances. And these are data going back about 2 years, and the project has slowly ramped up over that time frame. We really had 2 sites in King County, People's Harm Reduction Alliance and King County Public Health starting off, and other sites sort of coming on board over time in terms of the full sites. The data that I'm showing you here are the test results from these full sites, and these are based on the gas chromatography mass spectrometry, the secondary drug testing results. This is incredibly sensitive analysis that is done in a secondary laboratory, in this case at the University of North Carolina. And these are these cumulative data over 2 years, and this is well over 2,000 samples are represented here. And this is just to give you a really high perspective here in terms of what we're looking at, the 50,000-foot perspective on what we're seeing in the drug supply, and see the note in the corner because it's actually incredibly important. And this is the drug supply of the samples that people are bringing to us. There's no way we can say this is representative of the overall drug supply. We are in a limited number of places. There are certain folks coming in for certain reasons to have things tested. They may be more likely to bring in things they think are more likely problematic or adulterated. So this is in no way saying this is representative of the entire drug market. So that's important. It's hard not to interpret it that way, but that's not what these data represent. They represent the particular drugs that particular people bring in on a particular day to a particular place, and that's it. That said, we start to see some patterns over time and across places. So overall, what we've seen is that over a third of all samples are positive for fentanyl. Almost a third are positive for methamphetamine. In the gray bar, other analgesics is essentially acetaminophen. And we almost only and always see that in combination with fentanyl. So when we see analgesics, it's because they're essentially in a fentanyl product. And then you'll see these two sort of blue cross-hatched bars. These are fentanyl analogs, and to the right, other novel synthetic opioids. And I mention those because they are kind of part and parcel of the leftmost column, which is fentanyl. It's very complicated to tease apart what is fentanyl, what is another biologically active fentanyl-related compound, what's a precursor, what's a metabolite, what's a degradant. It's really, really complicated. So I think the takeaway, though, is that the big picture here, which I'm trying to focus on, is we're mostly seeing fentanyl, then we're seeing methamphetamine, and then we're also seeing some of these other fentanyl compounds, usually alongside fentanyl, not always, but oftentimes. And then much less often, at about 10%, we're seeing cocaine. So we certainly still see cocaine out there. And in other data I'm not presenting today, we are seeing a bit of an uptick, again, in cocaine-related fatal overdoses. So it's important to be aware of. We're also seeing ketamine and related compounds. We're seeing a bit, not much, but some heroin. People are probably aware, but I will note it that, you know, in about 3 years, we went from an opioid market that was majority heroin to now is a majority fentanyl, by far, a dramatic switch. In purple, you're seeing the non-pharmaceutical benzodiazepines, and those are things like alprazolam and atizolam that are generally appear like a pharmaceutical benzodiazepine, like Xanax, for instance. And then on the rightmost side, you're seeing what is coming back is MDMA. Sometimes commonly known as ecstasy, chemically as MDMA. So that's a big picture about what we're seeing in the overall drug market. What you're not even seeing on this list are the two compounds I'm about to talk about, which is xylazine and BTMPS. We are seeing them, but in a big picture, they don't leap out. But more recently, they begin to emerge. Okay, so let me talk about xylazine. So xylazine is a very potent veterinary tranquilizer. It arrived first on the East Coast, and it's really become a major contaminant in fentanyl on the East Coast. In some cities, the majority of fentanyl actually has xylazine in it, and it's usually seen almost always alongside fentanyl. In the West Coast, xylazine is hit a bit later, and it has not become as common. So it sort of arrived and has stayed at this lower level, whereas on the East Coast, it kind of arrived, went up to this very dramatic level quite quickly, and has pretty much stayed there, or at least pretty common. And what you're going to hear more from Molly and Carrie later is some more about xylazine, the physical effects of it, both in terms of the exacerbating overdoses as a potent sedative, and also how it causes wounds. And we'll talk more about that. And you can see online here, on the right here, some of the samples of materials that have been put together. For instance, the New Mexico Harm Reduction Coalition, you can see some of the materials and flyers they've put out about xylazine for folks who are coming in to get drugs checked. These data are for Washington State. These are the same secondary lab testing results over this period of time. And what they're showing in the top graph is in the very beginning, back in the day, known as 2 years ago, we didn't see xylazine. Then xylazine sort of began to emerge in sort of last summer, and we've seen fairly consistent. I wouldn't make too much out of these little changes here, because this is percentages of samples, went from 6% to 4%. That to me just means it's gone up and it sort of stayed persistent at this fairly low level of all samples. So this is among all samples we've tested. So you can see that it's a low percentage of all samples. Below, we're looking specifically at where we see xylazine most often. And on the right side, what I'm showing here are the how often we're seeing it. The most common here is in xylazine powder. In the most recent quarter, so the third quarter of 2024, this summer, we saw about 15% of the samples positive for xylazine were fentanyl powder, 1% were fentanyl pill, 1% were heroin. So really, we're primarily talking about fentanyl powder. That's the main takeaway from this. So a couple of other ways to sort of look at this, different angles. Over the past 2 years, among the 75 samples that were positive for xylazine, 96% were fentanyl. So almost always xylazine is alongside fentanyl. On the flip side, so xylazine is almost always in fentanyl, but most fentanyl doesn't have xylazine in it. Let me say that again. When you see xylazine, you see it with fentanyl, but most fentanyl doesn't have xylazine in it. So specifically, the most recent data we have from this summer, xylazine was detected in 10% of fentanyl powder, 1% of fentanyl pills, also called M30s. They often have that stamp or imprint on them, and just 1 of 12 heroin samples. We had a very small number of heroin samples, so I'm not even showing you the percentage, but very uncommon. So again, as we just showed on the previous slide, again, predominantly in fentanyl powder. And really, I'm hearing from all sorts of folks, whether it's harm reduction folks or law enforcement, that powder is just increasingly common, generally, in particular when it comes to fentanyl. So another compound that I'm going to call BTMPS, because I didn't take enough chemistry to know how to say that. So in June 2024, BTMPS was first detected in the unregulated drug supply nationally in community drug checking testing programs. That's really where we first saw this and where we were alerted to it. And it has been and continues to be most commonly in products sold as and containing fentanyl. It is an industrial chemical. I hear it as like a plasticizer and all, you know, it's not meant for human consumption. So it's really this industrial chemical. And the effects of the substance and why it might be in the drug supply are not well understood. Speculation is rampant. You can go on the internet and see 30 different guesses, but we really, in my opinion, still don't know why it's in there. I think at the highest level, why it's in there, what we're seeing, and we have seen a decline in fentanyl-involved overdoses, non-fatal and fatal over the last year. And what we're generally hearing about the fentanyl supply is that there's still lots of fentanyl being sold, that the price hasn't changed very much, but the quality of it has changed a lot. It might not be fentanyl, it might be very weak, it might be other stuff in there. So again, if you're trying to maintain a market and for some reason it's seen as not as profitable, and it just always comes down to money. If it's seen as not as profitable, you would think the reason for BTMPS to be in there is somehow to sort of extend or bulk up or try to mimic some properties of fentanyl, although it's a very, very different compound. Ali, I do want to pause. I'm not looking at the chat, but I can see there are things in the chat. Are there any clarifying questions that I can respond to?
The only clarifying question was the chart that showed what fentanyl was. It's not what the samples were sold as, but what the samples were tested as. And Jason said correct. Everything else is just resources.
Oh, thank you. Yes, that's a very important sort of different way of looking at the data. That was among things that were sold as versus things that were tested as. That's very important to think about sort of which angle you're taking on looking at these data. Thank you for that clarification. A little bit more around the BTMPS. Really importantly, the sites that have the FTIR machine, that chemical analysis machine, not the test strips, because they're not test strips for BTMPS, but that have FTIR, they can detect BTMPS usually, typically on site. That's something that they are able to see. Sort of takeaways are, you know, if possible, people who use drugs should get them tested regularly. And then just to make it clear, you know, people having a serious health issue should, you know, consider, and they think it's related to fentanyl or other drugs, should consider seeing a medical provider and share information with BTMPS with them. As we'll hear later from Molly and Carrie, I want to be really clear, that's not an easy thing to do. It's not an easy thing to do practically or logistically or emotionally. And I think you'll often hear, hopefully, good things from, I know, Molly and Carrie, about sort of where and how you provide that care that's easily accessible in a non-judgmental way, so people will feel comfortable and trusting and having honest conversations around their substance use, which is just vital to good healthcare. So a little bit more on BTMPS. This is, again, these are, we limited this. We're trying to be very cautious and very conservative in this initial data presentation. And these data were updated today. They're different than they were yesterday, and we'll continue to update these data. They're going to be different in a couple of weeks, and we'll put those out. But as of this morning, and we narrowed our sample to those that were initially coded as not suspected of being cross-contaminated. We have other samples that we're not sure of and those have important information. We're still kind of trying to understand what that means. But fundamentally, what we're seeing is for 34 samples that we've seen all in the last 3 months that were positive for BTMPS. So that question, which angle we're looking at, super important. Among things testing positive for BTMPS, 31 of them were sold as fentanyl. 1 was sold as an M30, not clear whether that was suspected being fentanyl or not, but it was called M30. 1 was sold as heroin, and 1 was sold as methamphetamine. And I will note the 1 that was sold as methamphetamine, after sort of looking back on the data, the drug checking technician still expresses concern that may well have been cross-contaminated as well. So I want to note that. But again, what we're seeing here for BTMPS essentially is that when we see BTMPS, we are predominantly seeing it in fentanyl samples. Just a couple of things I want to mention here. On the left side here, similar to Los Angeles and Philadelphia, these are showing data for June, July, and August among fentanyl things that were sold as fentanyl, the proportion that had BTMPS. And I'll actually focus on this LA graph in the middle first. 0% of fentanyl was testing positive for BTMPS in June, 13% in July, 41% in August. Different pattern in Philadelphia, except hitting at the exact same time. And in fact, we're seeing it happening at the exact same time here in Washington State as well. So hit here in July, we first heard about this from the Community Drug Checking Network. And we actually just saw, from my perspective, for me today, we just started seeing in police evidence testing, there's some emergences, some positives there for BTMPS as well, which we just saw. I think that was this morning. And the percentages of samples, we're still kind of finalizing how we want to calculate those, but they went from none in June, increased in July, increased a bit more in September. So we're seeing a similar pattern where it's increasing. It's still a minority of cases for things sold as fentanyl, but we are seeing it. And in the lower left is an example of a patient flyer, a client flyer that comes out of University of North Carolina, so folks can see that. I'm almost sure we have a link at the very end to the University of North Carolina webpage, which is really wonderful. So I'm going to stop there. I can leave this up, Lex, if you want, or take it off. What do you prefer?
This is fine if you want to leave that up there, because I'll discuss this here. Hi, I am Lex. I am a drug checking technician, a TIR drug checking technician at the People's Harm Reduction Alliance in Seattle. And I'm just going to talk a little bit about what our capabilities for detecting xylazine and BTMPS are, and kind of what, how we use those conversations and discuss people's drug use behaviors around them when they show up. So I'll just talk about xylazine first. Xylazine, we do have test strips for, as Caleb mentioned. They are immunoassay strips are just generally not the most reliable tools. But at least with the xylazine test strips, they've been around for a while. And we've identified what will cause problems with them. Namely, lidocaine is a big issue with that, because we've been seeing a little bit of lidocaine in the fentanyl supply. Not enough for it to be kind of a regular problem. And interestingly enough, at our different drug checking sites where we serve, a different catchment area. And so there, even within the same city, different drug supplies. But yeah, so we've got the test strips for xylazine, and we can also detect it on the FTIR. The FTIR has a detection limit of about 5%, give or take a percent here and there. So what that means is we can detect everything in the substance that's present at higher than 5% in the overall kind of composition of the substance. So with xylazine, Typically we can see it. Typically it's, even if it's mixed in there, it's, at least liberal enough for it to show up around that 5% mark. A real difficulty is both with the FTIR and the way we get our GCMS results because of the DEA permits for those labs. We don't get any quantification data. So really kind of what we go by about quantification or the presence of something is kind of how it feels or what the user report is during those conversations, which is something this, just a really unique insight that we get from being able to offer this service. And so, yeah, xylazine tends to be, we tend to be able to see it if it's in the mix, unless it's mixed with other things. The other challenge there too, again with lidocaine, is because of the way the spectrography works, is that lidocaine and xylazine have very similar spectrum. They have similar activity at the same wavelength of light, which kind of makes it hard to discern, again, if xylazine is present, if lidocaine is also. But again, something that, we use in kind of like the kind of human end of the analysis, the kind of critical thinking is, how often do we see as a technician, how often do I see lidocaine from this area? The other things I know about this sample, and maybe if it's a participant who I've worked with before, like what do I know about the drugs that this person typically brings in? Do I expect to see lidocaine or not? But yeah, lidocaine is a real challenge. Is also kind of new recently over the past 6 months or so, shown up in the fentanyl supply in a very low amount, but just an unexpected place for it. Lidocaine is more often used as an adulterant in cocaine, as folks may be familiar. But yeah, so that's xylazine. We can use it for, we typically catch it with the test strips unless, again, we suspect that there's also something else in there. I will just mention that the xylazine test strips have cross-reactivity with methamphetamine, which can cause a lot of confusion. We haven't seen xylazine in methamphetamine samples. So, and we've done quite a bit of testing with them. That's just the nature of immunoassay strips. I'll spare you the chemistry of how they work and why that is. So yeah, that's that. And then we usually see it in the FTIR. And then with BTMS, we don't have a library reference standard for because it's so new. But we've newly developed, there is a reference that we're using. It's not, like it's we used from a drug sample where we first saw it in Portland, where it was first detected on FTIR. And, we're working on getting a perfect kind of lab reference, like a lab standard for it, because it's not a substance that's ever occurred in the drug supply before, or any of the kind of labs that we work with that do drug analysis or kind of psychoactive chemical analysis haven't needed one before. So, but with that said, we have quite a strong capability of detecting substances we don't have reference standards for. I've used kind of doing manual comparison using like spectral libraries, other chemical spectral libraries. And although we don't have one of those even for BTMS, the references that the community's developed where we've detected it in high amounts, give us quite an edge in identifying it when it's present at higher than that 5%. Because it's changed kind of purchasing and drug using behaviors, we're seeing it, we're wondering if we're going to see it in smaller amounts, which brings me to something about xylazine where, we do know that xylazine brings about some wounds, which we discussed about later, but we don't really know how long someone needs to be using xylazine for or how much they need to be using, which kind of brings in, why I mentioned the quantification data or kind of the challenge without having that. As drug users make informed choices that they don't want to buy or consume drugs that have xylazine in them, or BTMS if they can detect it before they use or before they buy again, it changes the way the supply looks. And, some folks have been talking about, what, if it's cut more or adulterated more with another substance or kind of a more inert filler like mannitol, or something like that, you know, and the xylazine becomes, or BTMS becomes harder to detect because it's there at less than 5%. How much or how long does someone have to use before we also catch some of the other, you know, indicators that there may be one of these drugs in their substance? For example, xylazine. We see fentanyl users come in sometimes with wounds and sometimes without wounds, just wondering if they, you know, wanting to get their drugs checked because they're aware of xylazine, and you know they've been using a particular supply or getting a new supply and are concerned, and you know, want to make, although they are choosing to use drugs, want to make choices that are kind of going to allow them to live a long time, or at least as healthy as possible. So yeah, that's a little bit about that. And on the, just closing out on that note about the value of having drug checking in a point of care, there are places like Blue Mountain, Heart to Heart, and Walla Walla, which provide drug checking alongside of other healthcare services. They have a nurse on staff. And it's incredible to be able to detect that and be able to set someone up with zero form, be able to talk to them about some other options they have, especially if they are one of those folks who has developed wounds and are coming to get their drugs checked because they're scared. You know, I think that as drug checking becomes more accessible to folks, it would be really wonderful to see it as a cause to kind of pair drug checking with being able to provide wound care, kind of more direct medical care at all SSP or harm reduction sites. You know, the conversations we have from drug checking around these two drugs, and particularly around fentanyl, tend to be people that are interested in kind of making a less harmful choice in the drugs they're consuming. And it's powerful to be able to offer that and be able to empower folks with information to do that. And it's always disappointing when we aren't able to provide wound care or health care always around like fully in the way that they may need, based on what they've been experiencing. So that's just from my side of things. Oh, and the theory about why BTMS in there. If you look at BTMS, did they drop the UNC mystery substance URL? I was trying to pull that up before.
We have some references at the end that we can share with folks, so.
Okay,
If
cool.
you
Yeah,
want, if you
there.
want to explain what your understanding is, that'd be great.
Yeah, the chemical name is Biz2244 tetramethyl piperdyl. Sebacate is the form that we think it is. And there's a lot of really brilliant chemical, like organic chemical analysis folks in the drug checking community, as well as like just a good mix of knowledge. And because of the structure of it, piperdyl, you know, 4-ANPP is something that occurs in fentanyl often. And the theory is that because the Biz or the BTMS has these two piperdyls on it, that it is the result of trying to use a new like starting chemical or kind of precursor. And this is because there's been major crackdown. Kind of again, this is caused by the drug war in theory, is because of the recent crackdown on analogs, and the, you know, U.S.-Chinese interagency kind of drug crackdown, particularly on fentanyl and the precursors that are developed there, but also as well as developed in India and Mexico originally. But that this crackdown on precursor chemicals has caused them to kind of attempt a different chemical synthesis to produce either the same precursor or precursor for a different, potentially stronger analog, which would be really difficult for us to manage in terms of what we're seeing now. So
Great. Thank you for all that context. Super helpful. Thank you, Lex. I'm going to hand it over and stop sharing and invite Carrie and Molly to introduce themselves and share with us what you all are seeing.
Cool. I'm gonna try to share my screen here. But yeah, really excited to be here. Thanks for having us. I think Lex just set us up pretty perfectly to talk about kind of more the context of medical care for wounds and drug user health in general, and how yeah, approaching healthcare from a harm reduction standpoint is so important. Here, I'm not sure what happened to my presenter version. Oh, there we go. Okay, cool. So I'm Carrie. I am a public health nurse at Seattle King County on the street medicine team. So we're doing street-based outreach to people who are experiencing unsheltered homelessness in King County, and also like harm reduction services. And there's, as we'll kind of talk about, like there's a huge intersection, at least locally, between people who are using drugs who are kind of at the highest risk of severe medical impacts and people who are unsheltered just because of this like intersection of vulnerabilities and barriers to care. I'll let Molly introduce herself.
Yeah, hi everyone. Thank you so much for having us. This has been really helpful so far. I'm Molly. I am a RN through Harborview's field-based programs. I work out of the REACH program on 3rd Avenue in Seattle on a team called Vital. We work with the highest utilizers of the jails and ERs, predominantly substance use care, primary care, which includes lots of wound care, and drug user health. So we will be doing our best in this short period of time to do a very quick 5-slide crash course of a deeper dive on wound care and drug user health that we do here with the Healthcare for the Homeless Network.
Yeah, we're going to try to shoot through this pretty quickly because Molly and I can both talk about wound care for forever. But a couple disclaimers. The next slide is going to have a picture of some xylazine-related wounds. So take care of yourself if you need to look away or whatever. It's going to be helpful for you. Because Molly and I both have practiced in Seattle and King County, we have not specifically seen a lot of wounds that we can definitely pinpoint to being purely kind of xylazine-related wounds, although I'm sure we've seen wounds that might have been a factor in or could have been, but people who use drugs in this area, and I think everywhere because of prohibition, there is a, for many decades, people have been having wounds. A lot of those are like related to venous stasis ulcers on the lower legs. Wounds in this population it's not a new issue, although xylazine wounds maybe have some particular flavor, which we'll talk about. And so definitely want to acknowledge that we're standing on the shoulders of people on the East Coast, colleagues and harm reductionists who have had to figure this information out in a complete lack of evidence-based information, had to kind of in the midst of a crisis, like figure out what to do and what was going on. Yeah, I just want to kind of promote that, like, this is a really good time if we're talking about xylazine, we're talking about wounds, to just push the idea that like there need to be more low barrier options for people, not just accessing clinical wound care, but also just like hygiene, bandaging materials, things that are going to help people take care of themselves and help keep these wounds from getting worse. So sorry, here's the picture. I should have said that before I clicked forward. So sorry. Some of the like specific characteristics of xylazine wounds, we don't really know exactly what the mechanism is behind why these wounds develop. It might be related to vasoconstriction, so like loss of blood flow to the area, which can cause wounds and make things harder to heal. They are often found in injection sites, but not always, and not always even found when folks are when the injection use is not even the route that people are using substances. Sometimes have been seen in people who are only smoking, which is really different than the majority of wounds that we've seen before, where they are associated usually with a site of injection or with like downstream vein issues. They kind of initially start, you can kind of see on the right side here, as like areas of discoloration that blister, then those open up into kind of smaller areas of tissue necrosis, and then those kind of coalesce into a larger wound. And without treatment and care, they can get larger and deeper with more tissue depth into deeper layers, from skin, soft tissue, muscle, tendon, and even down to the bone. So they're pretty, they can be pretty dramatic, and they can happen pretty quickly. But I have this quote that I found from a harm reduction journal article about these wounds. While xylazine-associated wounds are dramatic in appearance, it's important to note they often do respond well to appropriate wound care. So we're just going to talk a little bit about just what is basic wound care that people can kind of do for themselves and can be done in kind of low barrier outpatient settings.
Yeah. Thank you so much, Carrie. Yeah, we've had lots of contact with nurses over on the East Coast 2 years ago when xylazine was first making its way onto the scene. I held a harm reduction roundtable with a nurse from Philly who works with their Healthcare for the Homeless network, and she was excellent in reminding us that we may not know a ton about xylazine or why these wounds are being caused from xylazine, but we do know a lot about wounds, and at the end of the day, these are wounds. So the same principles of wound care that we would apply to any other wound, despite the cause, are going to be the gold standard of care for xylazine-related wounds. So what they found over on the East Coast is that basic timely wound care is shown to be the most effective thing for healing xylazine wounds and or reducing harm and preventing severe outcomes like severe infection or limb amputation. So at its most basic, the principles of wound care, I like to say it's what I call to patients the Goldilocks method. Goldilocks doesn't like things too much of one way or too much of the other way. She likes things just right. So having things just clean enough, just moist enough, covered, and repeat. So at its most basic principles, we want to make sure that wounds are getting cleansed, especially if somebody is living outside using xylazine or whatever drugs that they're using. Despite the reason of the wound, the number one thing that we want to be doing is cleaning that wound daily if possible, making sure that it's not too dry and that it's also not too wet, because you need to have just the perfectly moist environment to allow new skin cells to develop, but you don't want it to be too moist, because if wounds are sitting in moisture for too long, bacteria loves hot, covered, moist spaces. So that's when you start to see infection happening. But specifically what people with xylazine wounds should be watching out for are if there's something called necrosis, so dead tissue. So if that tissue starts to turn black and looks like the skin is dead and it's not regenerating, at that point, they would benefit from going to see a clinician and getting regular wound care and debridement, which means, taking off that dead tissue through various routes, depending on how extensive the dead tissue is. More advanced wounds and complications such as infection would definitely need a higher level of care. These are things that you definitely want to watch out for, because with xylazine, like Carrie said, we're not exactly completely certain why this is happening for people who are using xylazine, why the necrosis and the dead tissue is so much more common. But it can happen very quickly for people. The tissue dying and then the wounds progressing. So something that you want to be telling people to be looking for is look to see if there's any exposed bone or tendon, if they have a decreased range of motion in a limb, if there's numbness or tingling or problems with the circulation in the limb, and then looking for local infection, which would be looking for things like drainage, and if there's a lot of surrounding redness, if the area around the wound is really warm and tender, if there's a bad odor even after you cleanse the wound, and if there's abscesses in areas around the wound. And you also want to be looking for systemic infection signs, so fever, mental status changes, or severe illness. These are all things that would warrant sending somebody or referring somebody to urgently to go to an emergency department. So xylazine wounds, just like any other type of wounds, often don't need antibiotics unless you're showing any of these signs of infection. So basic principles of wound care and doing frequent wound care, making sure that the wound is clean, moist, covered, and continuing to repeat it as often as you can, and encouraging clients to do that. Those are the basic things that we would be telling people if xylazine was in their supply.
Sorry, it's on mute. So kind of big kind of question that might come to mind is like, so if wound care is really simple, why is this such a big deal? As we kind of talked about, these wounds can progress quickly and become pretty large and deep. But these, wounds have been common especially in our area, in people who use drugs for a really long time. The access to wound care has been a struggle for a really long time. Quick recognition and treatment of these wounds is really important, but the folks who are at the highest risk often are not able to access the resources that they need to take care of themselves for a variety of reasons. So understanding some of those systemic barriers is really foundational to figuring out how to increase early recognition and care for these wounds. So last year, the program that I work with, the Scalacan County Public Healthcare for Homeless Network, we partnered with a local advocacy group comprised of people with lived experience called Vocal Washington to host focus group sessions at a bunch of different harm reduction organizations throughout King County to just hear from folks like, what are your experiences with having wounds, caring for them while being unsheltered, somebody who uses drugs. So the quotes here on the slide are from those interviews. I think they really speak to just some of like how difficult it is, and how it can just be really like just wear on people, because a lot of times people have wounds that are chronic that they have for years, and like they get better, they get worse, they get infected, they have to go to the hospital, they get antibiotics, they get out of the hospital, the wound is better, it gets worse, and it can be really, really difficult. So some of the themes really are just like lack of access to supplies and hygiene facilities, relative prioritization, like especially if you're unhoused, your immediate survival is always the priority, and something like wound care might not be the thing that you're focused on in that moment. When people are using, especially fentanyl, which has a really short, I can't think of the word right now. It's like the
Duration.
Duration, thank you.
Yeah, or high. It's a really short high. People use a lot. Yeah.
I can't believe I just forgot the word duration. Thank you so much. Really short duration of time when they are well enough to get stuff done before they start feeling really sick and have to, like, that becomes the priority again. So if we're asking somebody to go to a clinic appointment or to an emergency room where they're going to have to sit for hours, that's really difficult for people. And they might also be worried about their belongings, their loved ones that they kind of watch out for. All sorts of reasons that accessing care is hard. Also, just stigma, past negative experiences with care. A lot of times people get inadequate treatment of their withdrawal symptoms and their pain. As you can imagine, these wounds are pretty painful. And if somebody's tolerance is pretty high, it's going to take a lot of opiates to meet that tolerance, and then additionally treat pain on top of that. So a lot of times people avoid care or leave early because they can't be in that situation anymore, and they have to go take care of themselves. And so we found that people were in these focus groups were really enthusiastic about receiving wound care supplies to take care of themselves, and low barrier access options like walk-in clinics, like the one at the Needle Exchange downtown in Seattle, street outreach-based care, other kind of walk-in based care, and outreach, like care going to people. Since we knew that there's this community need for more harm reduction oriented wound care and supplies, we started distributing wound care kits through my program last year. This is a picture of what we put in our kits. But they're really, not necessarily going to be the exact fancy dressings that are going to get a wound to necessarily heal, but at least can keep things from getting worse, from getting infected, and prevent some of those severe outcomes. So just really quickly, there's stuff to keep your hands clean, because most people don't have access to hand washing supplies, stuff to clean a wound, like saline and gauze, or like saline wipes that are often sold as piercing cleaning wipes. We want to avoid using stuff like alcohol or hydrogen peroxide, because those are harmful to the new skin cells that are trying to grow and close the wound. We put in some bath wipes so people can clean their skin around the wound. And then there's Xeriform is just kind of a greasy gauze that adds some moisture, and that feels pretty, for most people, it feels pretty nice. It like adds a little bit of a soothing kind of cool effect. It's a little bit antimicrobial, and then some other just kind of petroleum-based ointments that are pretty inexpensive. And then we put in absorbent pads. So this could be anything like an ABD pad, a super absorbent pad. People that I've worked with have even reported really good success with just using menstrual pads, which are way cheaper than medical supplies. And then something just to hold it all together. So roll gauze to wrap something, tape to secure it, ace wraps, something that's going to keep that all kind of in place.
Okay, so currently we don't know a whole lot about preventing xylazine-related wounds. Injection does seem to be the highest risk, but what's been seen, and then this is something also that our friends who are over in Philly working for Healthcare for the Homeless, is they were noticing that the relative safety of different methods is also still unknown, because wounds are showing up even in people who just report snorting or smoking or ingesting. And so that the ideology is that there is something that's happening to the veins and the capillaries and the vasculature further down limbs from where somebody is ingesting or taking in the xylazine, but the understanding as to why or the prevention is still relatively unknown. At this time, a harm reduction strategy to talk to clients about is avoiding recommending booty bumping, specifically until there's more information out, because there's a very high risk of infection and complications to the vasculature of booty bumping, and it can be associated with some very severe localized tissue necrosis. So test strips also might become more relevant as xylazine becomes more prevalent in the supply, so that people can make these informed decisions as to the route that they're wanting to use, if they're wanting to use, and also just to ensure, like Carrie said on the slide previously, to ensure that they have the right supplies harm reduction wise to take care of those wounds if they are to come. Like all things, for people who are interested in reducing their opiate use, buprenorphine and methadone are the gold standard in evidence-based treatments. So there are studies that are obviously showing that people's xylazine use goes down if people are on Suboxone or methadone or some form of MOUD. So including, harm reduction and motivational interviewing around medications for opioid use disorder with clients who might have xylazine-related wounds, this is another opportunity to talk to people about their use if they want to taper down. MOUD cuts the risk of death from all causes by at least 50%, as we know. So there are ways that we can tell people that you can reduce the risk of injection-related soft tissue infection, regardless of whether or not xylazine is present in the wound. This is something that we're talking to clients about no matter what they're using, how they're using. We're always talking to people about harm reduction around their wound care. So this would mean single-use supplies, so not reusing supplies, whether it's drug use supplies or wound care supplies. Cleaning surfaces really well, cleaning hands before and after drug use, before and after wound care, doing really good skin and vein care. And as we know, people who use drugs historically have been impacted by wounds and infections due to unregulated supply, but also stigma in healthcare settings where they are presenting for care, systemic barriers allowing them to get timely care. And this has been happening long before xylazine. So this is just yet another push for us to continue to work with clients and people who are using drugs to advocate for timely care for things like wounds that can become really bad really fast for folks. So xylazine-related wounds are less common right now, but we are still seeing all sorts of common wounds despite what's in the supply for people. One thing that we're seeing a lot as we're doing outreach is we're seeing a lot of venous stasis ulcers still. It's still very common despite how people are using, and it's caused by damage to veins over time, so that damage to veins that's not reversible. So these can develop or continue even if somebody's not currently injecting, and also even if someone's not using. So I think we say these things just to continue to remember, like, the harm reduction education and counseling doesn't stop no matter what's in the supply. It's just good to be aware that these things have always been impacting people and will continue to impact people. And xylazine, there's still so much that's unknown about how to prevent, but we can do really good education on preventing worsening infection or worsening risks around it.
Yeah, thanks, Molly. I think just a quick point of clarification, the potential risk around booty bumping with xylazine is
Yes, thank you.
we don't have, like, there's not evidence that has shown that. It's just kind of based on a precautionary idea that if it were to be associated with localized tissue necrosis, that would be a pretty high risk in terms of infection and other complications in that part of the body.
Yeah, thank you for that, Carrie.
Just kind of, this is a good time to talk about building up a robust network of access to wound care and hygiene facilities and just low barrier care for folks using drugs. So thank you much.
We only have 2 minutes, but there were a couple questions. So Linda asked, are sweat patches effective for testing for xylazine?
Will you say that again, Allie?
Are sweat patches effective for testing for xylazine?
What do they mean by that?
I'm not familiar with what a sweat patch for drug checking is. Or for is that for I'm not familiar with the mechanism of how that would check. So, but I would presume you could design one, I'm sure.
And then Rebecca asked, have you seen isoton? Oh, I cannot even pronounce that. It's also known as ISO. ISO.
Ben is nodding. Ben is saying no, I believe.
Yeah, I think Jason had put something in the chat too. As far as secondary results, we have not seen it. Yeah.
So on that point, I think we'll wrap up. I threw the summary in there rather than putting another slide on screen, but it was all just spoken to really nicely by Carrie and Molly and Lex and everyone. So I just really thank you for being here. I think, the bottom line is we are seeing new substances. You don't know what's in there. Drug check can help you know that. But bottom line, even as the supply remains volatile, it's really important for people to hopefully have relationships with folks providing harm reduction and healthcare services and really easy to access and kind locations. I mean, that's the bottom line, no matter what's happening with the drug supply, is that those things need to be available, and those are increasingly available in our state, thanks to folks who are here today. So I just want to say thank you all so much for joining us, and so much to everybody for joining us as well. So have a great afternoon. Thank you.